Okay, so now we've had we started a loading dose and a maintenance dose that we try to do some of it individualization, even though dosing this drug is hard. Um, so we ordered a level to get in 2 days, and um, so we now have CSS information. So what do we do once we have that? So the patient calls, didn't get their level in 48 hours, I guess, and called the clinic with double vision, trouble walking, and nausea. So these are all symptoms of overdose. So they probably have a higher concentration than what we want. So it's probably over 20 milligrams per liter or in that neighborhood. So they get a concentration and it's 25 milligrams per liter. So what more do you want to know? Well, you want to talk about, well, if they added any drugs, taken away any drugs, have they been taking their drug, or ask them how they've been taking their drug, etc. Um, and so what are you going to do? Well, normally we would put in 25 in here for our concentration that the patient got, our bioavailability that we were using, which was um, 0.95. We'd also have to add that salt form in there of 0.92, the dose rate we were giving, and we would be able to figure out the clearance. But we also know if this bioavailability and salt form and clearance all remain constant, then we can just make a proportion. And this is what we do for most drugs, right? We say that the CSS then is proportional to clearance. So we can say CSS average 1 is to dose rate 1 as CSS average 2 is to dose rate 2. But can we do this in this case? Absolutely not, because we know that clearance is not steady, right? Clearance is changing with concentration. So it's very important to know we can't use our handy dandy little proportion to figure out a new dosing regimen. So this is a way that Graves Cloyd decided to be able to determine um, a new concentration. We don't really use this. It's pretty cumbersome, and I don't think there's a lot of evidence for. I mean, they did a study and it's good, but we just don't use it because it's a little too hard. Same thing with using this Shiner nomogram, which is I really like this particular method, and I used to have students use it. It uses Bayesian kinetics. I don't know if you've heard about Bayesian kinetics before, but Bayesian theory is basically that the past is the best predictor of the future. So what it does is it utilizes predictive statistics to try to figure out from one level what your patient's VM and your KM and Vmax are. And it's just a little fancy thing that we use these ellipses, which are statistical ellipses for what your KM and Vmax are of your patient. So that's pretty crazy, right? So what are we going to do? We can't use our standard good old equation here. So what are we going to do? Well, we have some methods that you can use for this.